I know we said that this is going to be about viral illnesses, but they did want me to talk about asthma. Asthma in and of itself is not a viral illness. However, it is exacerbated a lot of times when our individuals, especially our older adults, do get some kind of viral illness. So we do see a combination of asthma in with those folks, especially if we have the older adults who are not able to be medication adherent for various reasons, or they are not even under the care of a physician at all for asthma. So I just kind of want to touch a little bit on asthma. First of all, what is it? Well, Gina describes it as a heterogeneous disease defined by the history of respiratory symptoms that vary over time and in intensity, together with a variable of expiratory airflow limitation. A lot of times we'll see this with airway hyperresponsiveness and airway inflammation. And the picture there shows you what a normal airway tract looks like. And then someone who has chronic asthma, you can see that over time they start having that chronic narrowing of the airway. And then when they have an acute exacerbation, it becomes very tight in there and difficult for them to move the air. Oops. So, diagnosis, the defining feature of asthma is the presence of the variability of the expiratory airway obstruction. The recommended diagnosis of it is a test for the spirometry with bronchiodilator response assessment, or bronchiodilator reversibility. There are different schools of thoughts on how long we should reassess assess for the reversibility. The Global Strategy for Asthma Management and Prevention report says that it needs to be assessed 10 to 15 minutes after administering the short-acting bronchodilator. American Thoracic Society and European Respiratory Society task force reports say at least 15 minutes. However, there was a study done of 165 studies in 2020 by Cavalazzi et al., who determined that even in older adults, even 30 minutes reevaluation was not enough time. A lot of them required at least 60 minutes before we saw that reversibility feature. So just know when you're testing your patients, and a lot of times we're not going to be doing these tests in the ER or in the hospital. You may if they're admitted, and they're admitted for an extended period of time, but we're not going to usually be doing these tests. But I want you to have an understanding of how it's diagnosed. So our testing for older adults is going to look different than it is for younger adults. Gina further recommends that additional testing needs to be done, and it needs to be done over multiple visits. And these tests need to be repeated. So again, it's not something that we're going to do in the acute setting so much, but we need to have an idea of how those diagnoses are reached. Diagnosis should be confirmed before you start them on a controller treatment. So if a patient comes into us, I work in the ED, if a patient comes into us, unless I know for a fact that they have a diagnosis of asthma and that they have been treated on it with some type of controller treatment, I'm not going to initiate that from the ER. I will refill a prescription if I know that they already are on the medication, but I will not give them an initial medication because, again, that testing needs to take place. So these are just some common causes and triggers. I think we're all familiar with these. So risk factors. A lot of our adults we see had asthma as a child, and then it went away, and then it may or may not come back as an adult. So some of them, it's persistent childhood asthma that didn't ever go away and they've dealt with it all their life, or it's a relapse of childhood asthma that comes back as an adult. Also, a lot of allergens can cause the asthma. Some of our medications, I mean, how many of our folks are on beta blockers, NSAIDs, and hormone replacement therapy? A lot of our older adults are going to have occupational exposure-related asthma, especially those that have worked in the minefields or worked with chemicals over a period of time, our janitors, our housekeepers, people who work in healthcare. So even someone who does baking for extended period of time gets that flour and all those other powdery dusts, and they can develop asthma over time. And of course, we know smoking, whether it be tobacco, marijuana, vaping. I get all these young folks in that have a sudden onset of asthma, and they're having the chest pain, and they're starting the vaping, and I just tell them, the jury is out. They're still out on this. There's a lot of conflicting information right now. We don't know what this is doing to your lungs. You're just now starting it, so go ahead and stop now. Because we just don't know what this is doing to the lungs. But I don't see a lot of older adults that are vaping, but every once in a while I'll get one that does. And then, of course, pollution. I don't know about you guys, but living in a big metroplex, we get a lot of pollution. What are the symptoms? Wheezing, coughing, shortness of breath, chest tightness. We're familiar with those symptoms. Risk factors for exacerbation includes if they are uncontrolled, if they're on their medications but they're not taking their medications correctly. There's a high SABA use associated with increased risk factors. If they're using more than one 200-dose canister a month, then that needs to be reevaluated. If they're not on inhaled corticosteroid treatment, again, that needs to be reevaluated as well. Other medical conditions. We know comorbidities always exacerbate these types of illnesses: obesity, chronic rhinosinusitis, GERD. Especially if they're having a lot of GERD symptoms at night, and then they end up inhaling, aspirating those acidic secretions, they're going to be at a higher risk for developing an exacerbation of their asthma. Pregnancy, food allergies, and then, of course, we've already talked about smoking, allergens, and air pollution. Also, we want to look at, if they're having an exacerbation, what are their psychosocial situations? What's the socioeconomic? We talked about, can they afford the medication? Some of these medications are expensive, and the insurance does not cover them very well on a lot of them, especially if we're starting to have to put them on a newer medication because they've been on the other one so long that it's just not working anymore. What is their lung function? And then what other tests do we need to do? If they have had a previous intubation or they had been admitted to the ICU for a previous asthma exacerbation, this is someone that you're going to want to really evaluate closely, because chances are you're going to need to consider admitting them to the hospital again, because if they've had an exacerbation or had to be intubated enough in the past that those extreme measures have had to be taken, then there's a chance that they're not going to pull out of the exacerbation as easily this time, and you're not going to be discharging them home from the ER. If they've had one severe exacerbation in the last 12 months, then they are at a higher risk of a more severe exacerbation with the next one. So treatment recommendations. We want to assess the extent of the exacerbation. We also want to start treatment with administration of a SABA. Most patients, what the recommendation is that we aren't using the nebulized treatments, but that we're actually using the inhaler, giving them 4 to 10 puffs every 20 minutes for the first hour, and then seeing how rapidly they reverse with the airflow limitation. They really recommend that we only use nebulization in life-threatening asthma events. But how many of us are using the bronchodilators, the handheld bronchodilators in the ER? We're all using the nebulizers. Yeah, that's what we have. It's quick and it's readily available. We also want to make sure of their oxygen flow, that we're controlling that, and that their SATs are maintained. We want to assess for a severe exacerbation, and if there is a severe exacerbation, again, we want to consider hospitalization, maybe even ICU.